rotation. And sometimes you're going to hear that a lot with patients for certain pathologies. They say, yeah, it's really hard for me to put on my coat or put on a bra or even reach overhead. All of these things kind of clue you in what structure is being affected. So range of motion is the biggest thing, because when I test for range of motion, I just ask the patient, all right, raise your shoulder or raise your arms above your head, put them behind your back, and that kind of just tells me a lot. If they are limited, like they can't do it, then I'm like, all right, let me try to move them passively. And if I can't move them passively either in almost all range of motion, then that kind of clues me in. Do they have an adhesive capsulitis or frozen shoulder, or do they have osteoarthritis going on? Because these are mechanical things that's blocking the range of motion. Whereas if, let's say, the person has limited active range of motion because of pain, but if I move their arm and I can get the full range of motion, then that kind of tells me that this is more of like a tendon or even a ligament or muscle-like issue. So things like rotator cuff tendonitis, a tear, or even like a labral injury, or even like biceps tendonitis. So already right there, I can, from range of motion, that already clues me into, is this a mechanical block, or is this more of a structural, like let's say more of a, I would say like a tendinous issue that's going on. And so this is just to kind of like, the reason why I put these pictures here. So the thing with frozen shoulder and OA, they can present very similarly. Patients can have limited range of motion in all directions. I know in the textbook it says adhesive capsulitis, decreased range of motion in all like areas, and generally external rotation is the first to go. That's sometimes they'll ask you about that. Oh, they have frozen shoulder. Which is the first range of motion that goes away? Is external rotation. And maybe they're expecting like, oh wow, this person really knows their anatomy. But be that as it may, they're going to have limited range of motion, whether they have frozen shoulder or osteoarthritis. The difference, sometimes you can tell with frozen shoulder, you move them, and yes, there's a locking, but you can kind of sort of move them a little bit, like there's almost like a soft endpoint. Whereas with, oh wait, this is like bone on bone, it's not moving. Like no matter what I do, it's stopped. But really the best way to kind of figure this out is to get an x-ray. And with adhesive capsulitis, it's the capsule that's frozen or stiff, but the joint is, for the most part, fine. Whereas in OA, you're going to see that narrow
if
space.
there is limited active form and passive form, like flexion, extension, or external internal rotation, that should be frozen shoulder or osteoarthritis. But it's limited active form but full passive form. That should be the ligament or the
as med students, and even as like your intern year, or even as like PGY2s, right? We are just inherently trained. These special tests are what's going to give you the answer. Yeah, maybe, but you have. I think the most important thing is the story, it's the patient's history. That is what's really. I can spend maybe like 5 minutes, listen to their story. I can already figure out what's going on, and I don't have to do all of these tests, because we think a test is what's going to lead us to. One test is associated with one thing, but what you're going to notice is that the sensitivity is high, meaning like it'll tell if the test is positive, there's something going on there, but the specificity is pretty crappy. So that's sort of the most important thing. But when you're in your training, definitely understand these, like know what they are, know what we generally test them for. So like Hawkins, like impingement signs, Hawkins, Neer, those are more like the rotator cuff tendonitis or impingement syndrome. The crossbody induction, AC joint, so all these things I have them in front of this. I won't go too much into it. But the ones I think are pretty good are the impingement signs, speeds, and Obriens. And I'll get into those. And this is just me mentioning like know them as you're starting your training, but as you kind of go further and further in your training, you're going to realize you're going to do fewer and fewer tests, and you're going to develop your own style. It is a very busy slide, but don't worry, I have pictures. I think pictures speak 1,000 words. Really, what I just want to go through, I mean, you can read these on your own time, but I would just go to the picture. But these are our impingement tests. So what do these impingement tests do? Essentially, what they're doing is, and if I were to go back to the slide, the rotator cuff, specifically the supraspinatus, it runs essentially from the supraspinous fossa of the scapula and attaches onto the greater tuberosity of the humerus. And what that does is it helps us with abducting our shoulder. And in that space, I kind of think of it as like a roof. The floor plan is the supraspinous fossa of the scapula, and the roof is kind of that AC joint / the subacromial bursa. And if things get inflamed, or if that space is too tight, it's going to pinch onto that tendon of the supraspinatus, and that's going to cause pain. And that's what most of these tests are just doing. You're just crunching down on that subacromial space. So things like Hawkins, and I'll just go through the pictures. Hawkins, Neers, and these are just what I put in parentheses are just ways I remember them. Because for Hawkins, it's almost like you're flapping your wings like a hawk. For Neers, I think of Neers to the ear because that's essentially what you're kind of passively flexing their shoulder towards their ear. And if they have pain around like 120 degrees of flexion, then that kind of clues me into, well, there's probably something going on with the rotator cuff. And that's what most of these sort of show me. And the empty can, I know that's our favorite one. You all probably can remember how to do that maneuver. But if not, I have it right here. But really what that is, it's not only are you kind of decreasing that space or punching it down, but you're really testing for strength there. Because if, yes, the person's in pain, as you're kind of applying that downward force on their forearm, and it's painful, yeah, especially it's the patient. If it's just a pain, but that's not their pain, then that's not what you're testing for. What you're testing for is to figure out is that reproducing their shoulder pain, which is what they're claiming. It's painful, but they're pretty strong. They're giving you some resistance. Then that tells me more it's like a tendinopathy. But if it goes down very easily, then that clues me in that it could be a tear. And I just want to also highlight here, because there's a reason why I put in sensitivity and specificity. Look at the sensitivities of these guys. 87%, 75 to 89%. But look at the specificity, 30 to 50%, 25 to 44. These are good tests to like figure out that maybe this is what's going on, but the history is kind of what clues you in. So here's the pictures. Like I said, picture speaks 1,000 words. So Hawkins, essentially you have the patient flex their shoulder about 90 degrees, and they flex their elbow 90 degrees. And what you do, you place one of your hands kind of proximal to the elbow, and then apply a passive internal rotation force along the distal forearm. I'm doing this on myself, and that's pretty uncomfortable. But with someone who actually has a rotator cuff tendonitis, you don't even need to like do that much. You just need to just bring it down a little bit, and they will say stop it. They'll probably punch you in the face. And this is where I kind of say this: you can do any one of these tests, but if one of them is positive, don't do the other. I would stress don't do the other because one, their whole exam is going to be guarded and it's going to be like tough to tell. But two, it's enough. It sort of tells you, all right, there's something going on here. I can kind of move on, or it sort of based on the history and the exam, I kind of have my answer here. So this is Neer's, bringing Neer to the ear. So essentially you have them maximally pronate so that the palm is actually facing towards you, and then you'll passively flex their shoulder or flex their arm all the way to the ear. And generally, if it causes pain at 120 degrees, then that's positive. for some sort of tendinopathy that could be going on. And then this is the empty can test. Y'all probably have seen this a bunch in med school, but essentially what you do, you just have them essentially like pronate, so that, or even you can tell them, pretend like you have two cans and you're pouring them out, and make sure that when they're flexing, always make sure that they actually 80 ducts their arms, maybe like 15 degrees. Because the reason for that is to make sure that they're in the scapular plane. And then you apply that downward force, and if it's really, really weak, then that clues you into a tear. But if it's like pretty strong, but it's painful, then it's most likely a tendonitis. Now, speeds test. This is testing for biceps tendonitis.
Flex shoulder,
So what
90
do you
degree
do with speed
flex.
test? So kind of in this picture,
And
just
abduct
have the
them
patient say,
with
I want you to
elbow
just
in
raise
flexation
the-
forearm in full
bring your arm
supination.
up to maybe about like, just maybe to like shoulder width, right? And then I say, have your arm up and have the palms pointing to the sky. And then what I do, I apply a distal downward force, and I say, try and bring your arm up against me. And once they do that, and they're like, oh, doc, I'm having some pain, and they point to, I would say, like the anterior, like glenohumeral joint area, then that kind of clues me in that there might be that could be a tendonitis of the long head of the biceps tendon. Because remember, the long head of the biceps tendon goes all the way to the glenoid labrum. So that's kind of where it inserts. And so it will usually be more anterior. And so that kind of clues me in that there could be some sort of a biceps tendonitis going on. And notice how sensitivity is 63, 90% below the specificity. And so again, the history and the history.
Keropok.
And doing maybe just testing strength, like bicep strength, and doing the speeds, that can kind of clue me in. It's just sort of like confirm my suspicion. Now, Obriens. So it kind of took me a minute to like figure out what exactly, like, why are we doing this? And then it kind of became one of my favorite exams. The point of the Obriens test, it's almost like an impingement test or like an empty can test before the glenoid labrum. A lot of people come in with labral injuries. Generally, it's some sort of an acute event, like a bag, like maybe they're trying to catch something overhead, something really heavy, and then it just kind of like jerked their shoulders back a little bit. Or you see it a lot in like baseball pitchers because they're just really grinding down on that labrum. And so, or they could just be lifting something really heavy, like working out, and then they felt something in their shoulder, and they usually say, my shoulder feels really tired, or I feel like it's about to pop, but it doesn't really. So one of the things, what Obriens does, it's like an impingement test, but for the labrum. So what you have the patient do first, you start with a position that actually, you can do it either way. You can have them like with the palm pointing up or pointing down. It's really on how sensitive they are to the pain. But what I usually like to start off with is I actually have them point their hand, or almost maximally internally rotate their shoulder, and so palms facing towards you, and obviously they're flexing their shoulder to 90 degrees. And then what I do is you apply that distal downward force as a try and raise your arm against me. And then they're like, wow, actually that's really, really painful. I'm like, okay, now let me have you externally rotate. I don't tell them externally rotate, but I also say palms to the sky. Now, try and bring your arm up. And they actually say, you know what, that's not too bad. The reason why that happens is because when you maximally internally rotate the shoulder and you apply that downward force, you're almost like just cranking that superior glenoid labrum. You're really cranking it down. Whereas when you're when you're supinated, or the palms to the side, it's adding a lot less pressure there. And so that.
Obriens. Superior, labral, anterior, posterior lesion, or acromioclavicular pathology. Stand flexing shoulder to 90 degree, adducting to 10 to 15 horizontal adduction. Internal position 1, internal rotation. Oh, IR tuh internal rotation. Maximal ER berarti ngene for forearm and elbow in full extension. Oke, apa downward force to distal forearm against patient outward resistance. The above is repeated with shoulder externally rotated and indirect forward flexion position.
If their pain is felt kind of around that shoulder, like the anterior or even superior aspect of the shoulder, then that can kind of clue you in that there's probably some sort of labral issue going on. But if they say, oh, the pain is kind of more where the AC joint is, then that's kind of more like an AC joint dysfunction. But again, history tells you a lot of things, but this is just something that you can use to kind of clue you in. There's something going on with the labrum. But that area has a lot of things going on. Remember what attaches to the labrum? The long head of the biceps tendon. So maybe there could maybe be some compromise of the biceps tendon.
Superior, labrar,
so that's why, even though
anterior, posterior lesion, slap lesion.
60 to 100%. But I'll say for like let's say AC joint injury, there would be like 69 to 100% for like labrum, but the specificity is like 42 to 98%. So again, history kind of clues you in, but I'm just showing you these are the tests that I do to kind of help me sort of figure out what could potentially be going on. So now I'm going to the knee. I really love this slide, and I'll even reference like where I got this from. There's a great playlist from UCSF.
Moving to the knee program.
They have a great series on how to do
injury, degenerative, elbow nggak ada.
Slide, but this is just such a great slide here. Not only does it say go back to anatomy, so the anatomy of the knee, right? You have the femur, you have the you have the medial, and you have the lateral condyles, and then you have the tibia, the patella, you have the LCL, the MCL, you have the ACL, and the PCL, and you have your menisci. It's pointing to each of these things that kind of tells you, it gives you different differentials. If they have an issue going on, maybe around like the condyles, okay, maybe it's either going to be arthritis, like a degenerative process, or it could be like an actual acute chondral injury that went on. If they're having pain sort of around where the menisci are, it could either be a tear just based on their history, or it could just be arthritis that's just grinding it down, and so on and so on. And so this is why I say, if you understand your anatomy, if you know where they're pointing, you have a good idea what could be affected. And based on their story, you have a good understanding, like, maybe this is what's happening. So same thing, knee exam, I'm really just kind of going to go through the things that I think are really important. And the most important thing, and I didn't even mention this for the shoulder, but for any kind of joint, check both sides. Both sides are going to, the intact side is going to give you a lot of information. It's your frame of reference. And so inspection, palpation, and obviously the special tests here are the ones that I kind of like emphasize on. So this is a pretty busy slide, but what I'm really just trying to get at is, like, this is just my general flow of things. I first look, and what do I mean by inspection? I don't mean I am looking at the knee itself. I am looking at the patient as they're walking into the office or into the exam room. Are they limping? Do they have an assisted device with them, like a cane or a walker? Do they have a brace on? Because these things kind of clue me in, okay, there's probably something going on, or maybe they had like a prior injury, and maybe it could be aggravated, or maybe they re-injured it. I'm unsure, but it's just something to kind of keep in your brain. And then when you're in the exam room, generally for like a pretty young, healthy individual coming in with knee pain, I honestly just have them, hey, can you try to do maybe like a single leg squat, or just do a regular squat? And what I'm looking for, not only to see if their knee pain is reproduced, and if it is, where exactly is it, but I also do this to see, is their patella moving, like, is their knee kind of moving a lot more inward when they're doing these tests? Because that can clue me in that maybe they're having this pain because of a muscle like imbalance issue. So things like patellofemoral pain syndrome, or runner's knee, is a muscle imbalance problem. And I can gain that from just them doing a squat. Arthritis, obviously, you're grinding on that joint, you're putting weight on it, that's gonna create quite a bit of pain. Meniscus, same thing, you're really squeezing on that, like grinding on that meniscus. And if they say, yeah, that really hurts, then already it can kind of like clue me in. These are like the three things I start sort of thinking about. And then the next thing, I have them sit on the exam bed, and then I look for swelling. I look for swelling, maybe, and if it's like a diffuse, and I'll get into like the diffusions, but if it's like diffuse swelling, or even localized, that can kind of tell me, okay, is this like ligament, is this arthritis, or could it be gout? Never forget about gout. Never, ever, ever forget about gout, because that is way more common than you think. So if they have swelling and erythema, then I start thinking infection. I think of gout, or even think of rheumatoid arthritis. That's where the history kind of comes in. So swelling, erythema. I don't really look so much at like muscle atrophy, but just a nice pearl. If you look at their vastus medialis, if you see that that's not as plump, like very muscular, compared to like the intact side of that one, that could be because they have really bad medial OA. And so whenever they're like grinding on that joint it causes this pain inhibition of the vastus medialis to activate. And if you don't use it, you lose it. And so that could lead to atrophy. So that's something that you can kind of clue in there. Deformity, so what I mean by that, it's kind of the same thing up here. When I see them do that squat and I like sort of see the knee going in, or even when they're not squatting, when I see their knees are turned in a lot more, or their foot is like kind of overpronated, or rather it's just, they're sort of like
inspection, look, gate-nya kayak gimana, pincang, pakai apa, assistive device, atau ya pakai assistive device atau enggak. Terus bisa nggak dia melakukan single or regular squat, apakah ada pain, patellofemoral pain syndrome, osteoarthritis, atau meniscus injury. Kemudian ada yang namanya SEADS, SEADS, swelling, erythema, atrophy, deformity, dan surgical scar. Paling gampang S yang pertama swelling, dari ligament injury bisa osteoarthritis, infection, gout arthritis, and rheumatoid arthritis. A, erythema, infection, gout, and rheumatoid arthritis. A, atrophy, vastus medialis, pain inhibition of vastus medialis activation. Okay. Osteoarthritis, medial jetilan narrowed and cause pain inhibition of vastus medial activation. Deformity, valgus knee and overpronated foot, PFPS. S yang terakhir adalah surgical scar.
On the edge of their feet, it kind of puts me in that the angulation could be of their tibia, could be affecting their knee, and that's something that's like a risk factor for runners.
Local effusion and diffuse effusion. Swelling. Non-movable from soft tissue technique. Oke, jadi palpation itu ada effusion, bengkak, cairan, ada akumulasi cairan. Akumulasi cairan ada diffuse, ada localized. Kalau yang localized itu bursitis, diffuse itu berarti ada intra-articular damage, OA, ACL, PCL injury, sama dislocation.
And then surgical scar. But the biggest things I look at swelling and erythema. Palpation is just feeling. So if I notice there's swelling, I gotta first realize, is it diffuse? Like, is it all over? Is it all around the knee, or is it localized? Like a prepatellar bursitis, or even like a pes answer bursitis, they're mostly localized. But a more diffuse effusion is like, you can like see, and I'll show a good picture of this, but you have dimples around the knee. And if you see on the intact side, those dimples are there, but on the other side, that medial like knee dimple is pretty much bulbous or gone, and that clues me in that there might be some sort of intra-articular damage going on. And what's within that joint? So the ACL and the PCL. or even osteoarthritis can cause those. So that's sort of what I meant by diffuse versus localized. And sometimes the diffusion may not be that prevalent. And so what I really do is I just kind of put my thumb and my finger just slightly above the patella, and I just push down from like almost like the proximal or like the distal quad tendon. Sometimes it's called the suprapatellar pouch with the other hand. And if you see both of your fingers spreading out, then that's a positive like test that they have some trace injury. Maybe this is an injury like a tear that's just got a little bit better, but there's still some effusion like swelling. And then also I just sort of like palpate sort of the patellar tendon. If there's pain with that, and if that's what their pain is, then that kind of gives me an okay, maybe it's a patellar tendonitis. Same thing for the quad tendon. Palpate that, and even sometimes I have them activate their quads against resistance, and if that produces their pain and it's that area, then that's more of a quad tendonitis. And then I go for the money, and that's the medial and lateral joint ligaments. Now, when you do this, be sure. Use one finger. You can use a finger, your pointing finger, or use your thumb, but just use one of those things. Do not use both, like palpate both joint lines at the same time. Because if they say ow, you're not really going to know which one. You're going to have to ask them, oh, where is it? And that takes up time. So start either medial or lateral, it doesn't matter. Palpate around all the way to the back. And generally, pain on palpation.
Kalau palpasi, jangan langsung di dua dengkulnya. Jadi salah satu aja, karena kalau kamu baca dua-duanya dan pasien bilang aduh sakit, kamu nggak tahu yang kanan atau yang kiri, sebenarnya bisa ditanya. Tapi secara teori mending salah satu aja.
The head of the calf muscles are in that area too, so maybe they could be having tendonitis
head
there
of the
as well.
calf muscle.
So this is what I meant by the fusion. You can clearly see you have that dimple right here at the knee, and you can look at your own knees when you do this. See, it's really sunken there, but then look how it's just blown out. And it's even kind of more blown out here too. I didn't even put it in a circle, but right here as well. It's a lot more caved in, it's more concave, it's way more convex. So that kind of tells me something's going on here. It's either gout, it could be like maybe like a ligamentous injury, or it could be a like, judging by these knees, I don't know, it's a fairly young person, so it could be some sort of like a ligamentous process. Anywho, now we're at the special tests. So same thing, special tests, they're good, but you need the history to kind of like, you need the whole picture. But these are the general tests that I will do if I'm suspicious of something. So again, busy slide, but I like pictures more because they say they speak 1,000 words. But Lachman slide will do if I'm suspicious of something. So for the general tests that I will do, but I like pictures more because they say they speak 1,000 words. But Lachman. So Lachman and
the knee
Anterior
slightly bent.
kind of fairly similar test.
The examiner stabilizes the femur and then applies anterior forwards first to tibia, attempting to move it forward in relation to the femur.
And the reason why you actually do that is because that's probably the most, like I would say, the most loose that knee is. And essentially what you do, you kind of stabilize the femur with one hand, and then with the other, you kind of just pull upon like the back of the tibia or like the calf towards you, almost like you're sort of like starting a chainsaw, like you're revving it up towards you. And generally, if you see the test is positive, if like you see a displacement like greater than 5 millimeters. So what does that mean? Honestly, if you just use the other side to compare. If the other side, like there's a firm endpoint, but then you do it on the problematic side, and it's like, okay, wow, it's really coming towards me. Then that clues you in that it's either a partial or a complete tear of the ACL. And the reason why people actually like Lachman's more than anterior drawer is that not only is the sensitivity great for acute tears, but the specificity is like 95% for acute tears as well. Anterior drawer, a lot of you probably know the anterior drawer test, but regardless, have the patient bend their knee 90 degrees. You sit on their foot to stabilize it, and you use your thumbs. You palpate the I would say like the tibial flares, and you would just pull, just gently sort of like pull their tibia towards you. And if you see excessive displacement compared to the intact side, like very like excessive, then again, clues you into the ACL. Now, these are good at detecting chronic injuries, at least for the anterior drawer. So if someone's like maybe an older gentleman or older lady, then I'll probably do anterior drawer. But for someone younger, or like, let's say somebody had like a non-contact injury, I kind of go for Lachman's because that's going to clue you into the acute tear. Now, if you're on the sideline and you see an athlete just injure themselves, and you're thinking, oh my gosh, like they did a cut and they said it and they just went down easily. And they're like, I'm in a lot of pain. I felt like I heard something, and you see it super swollen. Chances are that these tests are going to be positive are very, very slim, because that joint, you only got one chance to do these tests. And as soon as you do it, that knee is going to lock up because of their acute inflammatory process. So a lot of these will give like false negatives if you're doing this from like the sideline for acute injury.
Posterior
That's why you sometimes kind of like give them like maybe just like 1 or 2 days. But the first thing you're going to do, you're going to MRI them. Like that's I mean, just based off of the history and the exam, looking at them, yeah, you're going to get an MRI. And then the posterior drawer is just opposite of the anterior drawer, and this is just a test for PCL. If this is positive, meaning that tibia kind of moves further back, then that kind of clues me in that this is probably a PCL injury. And so this is what I mean by, as you can see here, the Lachman test. You have the patient flex their knee 20 degrees, stabilize the femur with one hand, and you just pull that tibia towards you. And if you see about greater than 5 millimeter displacement compared to the other side, then it's positive. Here's the anterior drawer, kind of the same thing. You stabilize the leg by sitting on your foot, bring it towards you, positive, kind of leads you into ACL. Posterior drawer, same thing. If it's excessive displacement posteriorly, then that puts you into a PCL injury. And then here, the Valgus stress test and the Varus stress test. These I'm really just testing for the integrity of the MCL and the PCL. So these switches are swapped, but Valgus stress test, essentially what I'm doing here is I am testing for the MCL. And how do I do that? So I place there, that drawer, tibia kind of moves further back, and that kind of clues me in that this is probably a PCL injury. Moves further back, and that kind of clues me in that this is a behind state displacement. Then here, clearly, then that clues you in to a PCL injury. And then here, the Valgus stress test and the Varus stress test. These I'm really just testing for the integrity of the MCL and the PCL. So these switches are swapped, but Valgus stress test. Essentially, what I'm doing here is I am testing for the MCL. And how do I do that? So I place one of my hands at the distal end, kind of like at the ankle of the problematic side of the knee, and then I place my hand along the outside of the knee. And then what I do, valgus means kind of like bending towards the body, or almost like an angulation. I push along that to create a valgus like moment or a valgus stress. And what I'm doing
Sekitar
is
30 derajat. Kalau valgus stress
and
test itu untuk ngecek medial collateral ligamenya di pus. Kalau yang Varus stress test berarti di pus yang keluar collateral.
Put a lot of pressure on the medial aspect so that you can push along that lateral collateral ligament. The reason why I think something that's important is you want to make sure that you do these tests initially as like with the knee fully flexed, and then you have it bent at 20 to 30 degrees. Why 20 to 30 degrees? Oh, sorry, why 20 to 30 degrees?
Valgus MCL, benar. Valgus MCL.
That is actually, again, that's probably the most loose, like relaxed that the knee joint is going to be in. And so if you see a lot of, let's say, medial displacement, like if that boat, again, 30 degrees. Why 20 to 30 degrees? Oh, sorry, why 20 to 30 degrees? That is actually, again, that's probably the most loose, like relaxed that the knee joint is going to be in. And so if you see a lot of, let's say, medial displacement, like if that bowing is way more than on the other side, and it's very painful too, then that's positive, and that can kind of clue you into either an MCL or an LCL. And if you are worried about an MCL injury, I'm not going to ask questions in the chat, but then you can kind of think more like, well, what's connected to the MCL? Well, we've got the ACL and the medial meniscus. That's a high yield concept. If you're worried about an ACL injury or a medial meniscal injury, best believe you got to think about, all right, I want to make sure that these, like all these three structures aren't involved. So very, very, very high yields. And then the last one is McMurray's. This, by the life of me, was probably the most confusing exam as a med student, but then they just required one thing to make it easy. But what is McMurray's test for? essentially what you're doing, you're testing to make sure that the person doesn't have like a meniscal injury or some sort of derangement. And so how do you test this? Well, what you first do, you actually like put, doesn't matter which hand, but you put your finger and your thumb and your index finger along the medial and lateral joint lines, and then you put your hand along the other hand along the heel of the patient. And the first thing you want to do is flex them, like flex them fully. Why do I say that? Because that in itself is a test for meniscal injury. Because what you're doing is you're crunching down on that posterior horn of the menisci. And if they're like, oh my God.
On the set to be tested, supine lying with the knee flexed. On the set to be tested, proximal hand hold the knee and palpate the joint line, thumb on one side and fingers on other. Okay. Distal hand hold the sole of the foot and acts to support the limb and provide the required movement through range. From a position of maximal flexion, extend the knee with internal rotation of the tibia and varus stress. Internal rotation of the tibia and then varus stress. Then return to maximal flexion and extend the knee with external rotation of the tibia and valgus stress. Okay, external rotation and valgus stress. Okay.
Wow, that's really bad. Okay, that kind of clues me in, especially with maximal flexion. Okay, there may be something going on with the meniscus, but just to really make sure, I'm going to be a huge butt face and grind on it. And what do I mean by grind? So with the hand on the heel, I am either going to twist the heel in or twist the heel out.
External or internal?
Something that really helps me is this. Wherever you're pointing the heel, that, like if you're pointing it inside or medially, that is the meniscus you are testing. You're testing for the medial meniscus. But if you're pointing it outwards, then you're testing the lateral meniscus. And the whole, as you're extending, make sure to apply a Varus or a Valgus. If you just let the heel guide you, the heel will guide you to the most natural way the leg is going to come out. So if you move it in, it's going to naturally, I would sometimes just call it like you're externally rotating the tibia. But when you're pointing the heel in, the leg is going to want to naturally do a bit of like a valgus movement. And then if you turn the heel out, or that's kind of more internally rotating your tibia, and you do this on yourself, like you see, point your heel in and then point your heel out, and you see which direction the tibia is going. When you extend it with internal rotation of the tibia, the knee is going to want to have a valgus moment. And so let the heel guide you. But yeah, if any of those positive will just be pain. And also the reason why you're putting your thumb and your finger along the medial and lateral joints, if you feel clicking or locking or even pain along those joint lines, then it's positive. And you'll feel those things with your fingers. So that's pretty much it. I know this was pretty fast. Hopefully you all were able to get something, but here are the resources and references. The UCSF Sports Medicine Lecture Series. So that you can copy and paste this. Really, really great resource for not just shoulder and knee, but elbow, hand, foot, ankle, back too. And then Physiopedia is always a great place to kind of find sensitivity and specificity for certain exam maneuvers. And this is just a shameless plug, since I'm from Jefferson. This 3-minute MSK verbal nerve exam was created by our very own Dr. Hecker and Dr. Onkum, and a bunch of other physicians as well, but Dr. Hecker and Dr. Onkum are my bosses essentially, / attendings. And this is just a really, really great comprehensive book that I think all of y'all should get, especially prior to starting your away rotations or starting your PM&R rotations, just to get a good understanding of MSK exams and verbal nerve exam. All right.
Thanks.
Okay.
That was awesome. Thank you so much.
Shoulder.
Alright, so
anatomy checklist lah. Mana? Terus tes ya, special test. Special test no Hawkins. terjadi, dimana fleksi, shouldernya fleksi, shouldernya shouldernya abduksi, terus elbownya diangkat ke atas, Hawkins kira di rest. Terus apa namanya, Neer test, Neer sing ini enggak. Terus apa, antigen test, antigen sing jempol ke bawah dua-duanya, terus dikasih tahanan ke bawah, nah ini nahan. Terus shoulder mau yang misalnya ada nyeri aktif arom dan perom, itu berarti possible caused by frozen shoulder atau OA. Yang active from nyeri tapi passive from-nya tidak nyeri, kemungkinan tendon problem. Terus apa namanya ya? Obriens kiseng internal rotation sama external rotation. Oke. Terus apa namanya? Oke, malah sini.
Oh, patient.
Obriens. Speed test. Obriens sing internal sama external rotation sama speed test. Speed test ini untuk ngecek biceps tendonitis. Intinya dia fleksi, terus dia abduksi 10 derajat di ini dia ngangkat ke atas tapi ada tahanan ke bawah. Kalau misalnya positif ya biceps tendonitis. Terus knee exam. Anatomi clear. Terus ada physical examination PE. Satu inspeksi dilihat dari gate-nya, terus ada SEADS, swelling, erythema, A-nya atrofi, deformity, sama scars of surgery. Terus ada palpasi, itu palpasi cek effusion, lokal or diffuse. Terus apa namanya? Itu ya yang lain-lain jelas lah. Sudah nyeri tekan, palpasi di sekitar patelanya. Oke. Palpasi di sekitar patella femoral. Terus palpasi di belakangnya popliteal fossa. Karena di situ ada ujung dari calf, hamstring, meniscus, Baker kiss juga bisa. Terus inspection, palpation, terus ada special test ya. Special test pertama Lachman 20-30 derajat, terus ditarik ke atas, ditarik ke pemeriksa dengkulnya, kemudian anterior drawer test, ini posisi 90 derajat, terus posisi pemeriksa duduk di atas kaki pasien biar lebih stabil. Yang posterior drawer test itu ya anterior ditarik ke arah pemeriksa, posterior ke berlawanan dengan pemeriksa. Terus ono valgus stress test. Valgus stress test. Valgus stress test berarti untuk cek valgum medial collateral ligament. Terus ada Varus stress test untuk cek lateral collateral ligament. Caranya adalah dengan difleksikan sedikit 20-30 derajat karena itu posisi paling rileks, kemudian didorong aja ke lateral ya berarti lateral collateral ligament, ke medial berarti medial collateral ligament. Terus ono McMurray untuk cek meniskus hampir sama. Kalau internal rotation itu untuk cek yang lateral, external rotation untuk cek yang medial meniskus dan lateral meniskus.
In an anterior drawer, this by the, and you'll see which direction the tip starts tendons.
Car stops.
Positions as well.
Easy.
Or essentially, and this is just a really, really great comprehensive